My name is Dr. Safia Akhlaq. I am a medicine resident year 3 in Khan University Hospital, Karachi. Today I would like to present uh, my case series on topic COVID-19 ARDS and successful outcomes. This presentation of the case series is of two index cases which were seen and managed in early COVID-19 pandemic days, when COVID-19 was a novel entity and its management approaches were still in the evolving phase. So here I proceed with my case presentation. Two patients with hypoxic respiratory failure presented in emergency and diagnosed as COVID-19 with ARDS. Case 1 is 72-year-old male with no prior comorbids, presented with complaint of fever and shortness of breath for 6 days. The PF ratio was 190 and chest X-ray showing bilateral peripheral lung infiltrates. Similarly, the case 2 is of young 34-year-old male with no prior comorbids, presented with fever of 9 days and dry cough for 3 days. The PF ratio was 202 and chest X-ray showing bilateral peripheral lung infiltrates. The hospital course was of these both cases were just like that. Both cases were given the supplemental oxygen. However, case 1 had given the additional support of non-invasive ventilation via CPAP. Awake proning sessions according to the Intensive Care Society guidelines were initiated, along with kept in the negative fluid balance of around 700 ml to 1000 ml daily with the aid of furosemide infusion. And the systemic steroids were also administered in addition. Both cases were discharged home on room air on 10th and 7 days of hospitalization respectively. On follow-up visit, after 1 week, both cases were doing clinically well. So the management was between the three main core management points, which is systemic steroids, the awake proning protocol, and the negative fluid balance. So the outcome is in front of you all. The case 1 chest X-ray on arrival show significant peripheral infiltrates, bilateral, more than 50% of the X-ray, as you can see, is involved with the infiltrates. And on the discharge, the X-ray is significantly improved, but there was a remarkable improvement in the case 2. The young male with 34 years of age. On arrival, the X-ray showing bilateral involvement, peripheral in both lung fields. But on discharge, you can see it's improved significantly. So that's a very dramatical improvement in our setting we have seen with these three core management points. So I'd like to proceed further. So what makes our case 2 we have this remarkable improvement and successful outcome? So I would like to just have a few time to talk about the awake proning. So the early application of the prolonged prone positioning sessions and negative fluid balance dramatically decreased the mortality in intubated mechanically ventilated patients with severe ARDS. It was known fact that we have intubated mechanically ventilated patients who have significant improvement. But the benefits of prone positioning in non-intubated awake patients was lacking in the literature until the novel COVID-19 surged, which had choked the healthcare system, and dearth of the mechanical ventilation provoked the need for an alternative solution to prevent the complication and mortality related to the deadly coronavirus. So the physiology of prone positioning is like is essential to understand its benefit. The part of the lung is considered well ventilated where the alveolar pressure exceeds the pleural pressure. So in a supine position, the weight of the ventral lungs, heart and abdominal viscera increases the dorsal pleural pressure, which leads to reduced transpulmonary pressure in the dorsal lung regions due to the compression. The increased mass of the edematous ARDS lung further increases the ventrodorsal pleural pressure gradient and reduces the regional ventilation of the dependent dorsal regions. Likewise, in the prone positioning, the dorsal lung will get increased ventilation due to the reduced pleural pressure, increased alveolar pressure, and thus improve the oxygenation. So this technique was adopted in COVID-19 when the COVID-19 was on its peak. So the awake warning in non-intubated patients, spontaneously breathing patients with have a successful outcome observed in our case series too. And there is always a question, okay, how can we do a awake warning protocol? So there was an ICS guidelines which says okay, it is recommended to have a 2 to 3 sessions for at least a total of 4 to 5 per hours, um, as we do in our both cases. The protocol was like, as the patient was awake, so he or she has to lie down on the belly for around 30 minutes, then on the right side, then sit up, and then left side, and that the cycle goes on for around 4 to 5 hours. And in a 24 hours, it should be 2 to 3 sessions to get a full benefit of awake proning. The second part of our management was negative fluid, which I like to emphasize. Again, it is well established that negative fluid balance is associated with reduced mortality, less time on the mechanical ventilation, and shorter length of the ICU stay in patients with ARDS. So the conclusion is that both patients had not only managed without the mechanical ventilation, but also without any antiviral like remdesivir specific immunomodulatory medication, that is tocilizumab. So there is always a question why tocilizumab and remdesivir was not administered to these two patients. They are a significant indication to have these both. So I would like to share why we haven't given tocilizumab or remdesivir to these patients because of the deranged LFTs and the transaminase due to COVID-19. I would like to share the values. Um, SGPT was 234 and SGOT is 237 in case 1. And similarly, in case 2, it was the SGPT was 468 and SGOT is 181. So due to the increased transaminase, the infectious disease was on board. They were reluctant to give tocilizumab or remdesivir. So we have no other choice just to manage without these two major drugs to manage these patients. So, so the take-home message with these case series and why I share these case series with you is like that the antiviral remdesivir and intravenous immunosuppressive drug, that is tocilizumab, both are highly expensive. Low or middle income countries like Pakistan, where basic health facilities not in the reach of everyone, these high cost pharmacological treatment options were a dream of a common people. So this raises more importance of awake warning position along with the negative fluid balance strategy, as it is cost effective and can be done outside the intensive care unit with or without assistance, and also helps to reduce the economic burden on healthcare system. So that's the major point to discuss it on the international forum, that we have to find out other ways, the cost effective ways to help people more. So thank you.